Our next speaker is Dr. Madhusmita Misra. Dr. Misra completed her pediatric endocrine fellowship at the Mass General Hospital and Masters in Public Health at the Harvard School of Public Health. She holds multiple appointments, including Associate Director of the Harvard Catalyst Translational and Clinical Research Center and Director of the Pediatric Endocrine, Sports Endocrine, Neuroendocrine Lab at Mass General. Dr. Misra has received multiple awards for her work, including the John Haddad Young Investigator Award given by the American Society of Bone Mineral Research. Dr. Misra is a Fritz Bradley Talbot and Nathan Bill Talbot Professor of Pediatrics at Harvard Medical School. She is the Chief of the Division of Pediatric Endocrinology at Mass General and Harvard Medical School. Dr. Misra will be talking to us about vitamin D treatment and management. Dr. Misra, thank you so much for being with us today.
Well, thank you very much for that introduction. And I just want to confirm that you can see my slides and you can hear me.
Yes, we can. We got you.
Okay. Terrific. Thank you. All right. So thank you very much to the organizers for inviting me to do this talk today. These are my disclosures, none of which are really relevant to the content of this talk. And I'll start by discussing a case that I think will be very familiar to most of us. So this is a 1-year-old dark-skinned boy who presented to the ED of a local hospital with fever, difficulty breathing, and cyanosis related to his underlying reactive airway disease. He was born at 36 weeks, and he has allergies to cow's milk, peanuts, and eggs diagnosed at 7 months. And incidental labs drawn at the time of this admission included a low calcium, a low phosphorus, and a high alkaline phosphatase. And he was treated for his reactive airway disease and was sent home on medications. And because he was not symptomatic, he did not receive any calcium infusions at the time, but we were asked to see him urgently the following day. So at the pediatric endocrine visit, the patient's mother reported that he'd been irritable, that his energy levels were low, that he would wake up crying from sleep, that he was trying to limit motion, that he preferred to crawl rather than walk with support, although previously he had been cruising. And she reported that he was mostly breastfed. He took some stage 2 baby food. He was not on any supplements. And on exam, he was at the lower percentiles for height and weight. He had significant frontal bossing. The anterior fontanelle was still open. He had 2 central incisors and no other teeth. There was bilateral widening of the wrists, and the rest of the exam was normal. So we repeated his labs, and his calcium was, as you can see, very low, as was the ionized calcium, and the phosphorus was even lower than in the ED. Magnesium and creatinine were in the normal range, and the 25-hydroxy vitamin D concentration was only 4 nanograms per ml. And the 125 dihydroxy D concentrations were in the low normal range. PTH was elevated, and alkaline phosphatase levels were high. Other electrolytes were normal, and the other liver function tests were also normal. And so he obviously has very severe vitamin D deficiency, and and he also had evidence of rickets, as shown in the radiographs here of the wrist and the knee, where you can see the cupped and frayed metaphyses and the widening and spraying of those bones. So what I'd like to do today is to talk to you about the physiology of vitamin D. I'll discuss some causes of vitamin D deficiency and resistance, the diagnosis, and the management. So starting with the sources of vitamin D, there are 3 sources. There is cutaneous synthesis of vitamin D on exposure to ultraviolet radiation. There are food sources, and there is transplacental passage from the mother to the fetus. So as regards cutaneous synthesis of vitamin D on exposure to ultraviolet radiation, there are 2 forms of ultraviolet radiation. There is UVA and UVB. Both UVA and UVB, if they're exposed to either of those in excess, will increase the risk of skin cancer. But it is UVB that is important for vitamin D synthesis in the skin. Now, in the early hours of the day and later in the day, we predominantly are exposed to UVA, while between 10 a.m. to 2 p.m., some would say 3 p.m. and maybe 4 p.m., the exposure is mostly to UVB. So when we are exposed to UVB, 7-dehydrocholesterol in skin gets converted to pre-vitamin D3, which will isomerize to vitamin D3. And vitamin D3 then circulates with D-binding protein and will go to the liver, where it gets 25-hydroxylated to 25-hydroxyvitamin D, and then 1-hydroxylated to 1,25-dihydroxyvitamin D, which is the active form of vitamin D, or calcitriol, as you know. And this is important for calcium phosphorus reabsorption. Now, 25-hydroxy-D can be inactivated by 24-hydroxylase to 24,25-dihydroxyvitamin D, and 1,25-dihydroxyvitamin D is also inactivated by 24-hydroxylase to 1,24,25-trihydroxyvitamin D. And certain anti-epileptics and antiretrovirals will increase 24-hydroxylase activity, leading to inactivation or increased metabolism of 25-hydroxy-D and 1,25-D. And that, as you know, is a cause of vitamin D deficiency. Now, PTH is intimately associated with vitamin D metabolism. And so PTH increases calcium reabsorption in the distal tubule of the kidney. It reduces phosphorus reabsorption. And by increasing 1-alpha hydroxylase activity, it increases calcitriol concentrations and therefore calcium and phosphorus absorption from the gut. It also increases calcium and phosphorus mobilization from bone. Now, here is a picture that shows the effect of increasing ultraviolet B exposure in terms of pre-vitamin D3 synthesis. So with increased duration of exposure, there is a rapid increase in pre-vitamin D3 levels, followed by a steady state. And subsequently, while the 7-dehydrocholesterol levels are going down, pre-vitamin D3 is not going up. What is going up is levosterol, which is one of the metabolites of dehydrocholesterol. Now, just 5 to 30 minutes of sun exposure daily, or at least twice a week, between 10 a.m. and 4 p.m. to the exposed regions of the body, particularly the face, arms, hands, and legs without any sunscreen has been shown to lead to sufficient vitamin D synthesis in the summer months, enough not to cause any vitamin D deficiency. However, we know that we are recommended to use sunscreen with an SPF of 15 or higher to avoid skin cancer. And as I'll show you in a minute, that per se can reduce the efficacy of sunlight in terms of causing cutaneous vitamin D synthesis in sufficient amounts. Now, it turns out that the moderate use of commercial tanning beds that emit 2 to 6% of ultraviolet B radiation can be effective in bringing about sufficient vitamin D synthesis. Now, here are some dietary sources of vitamin D. We know that the fatty fish have high concentrations of vitamin D. Cod liver oil is a very rich source of vitamin D. And fortified foods such as cereals, orange juice, milk, and formula, of course, have high concentrations of vitamin D. In contrast, breast milk has very, very low levels of vitamin D. And the third source, as I alluded to before, is the transplacental passage of vitamin D from the mother to the fetus. Now, when there is a deficient state, there is adequate gut absorption of calcium and phosphorus because of adequate production of calcitriol. And when calcium and phosphorus levels are sufficient, PTH levels are sufficient, and the normal range, and bone calcium and phosphorus are preserved. Now, in mild to moderate vitamin D deficiency, the initial slight decrease in calcium leads to an increase in PTH, which increases the mobilization of calcium and phosphorus from bone, and that leads to increase in demineralization of bone. There is an increase in calcium reabsorption from the kidneys with a decrease in phosphorus reabsorption. And because of the increased 1-hydroxylase activity, there is increased gut calcium and phosphorus absorption from increased calcitriol production. So as a consequence of these adaptive mechanisms, in mild to moderate vitamin D deficiency, calcium levels are normal, but because of the reduced phosphorus reabsorption in the kidney, phosphorus levels could be low. Now, in severe vitamin D deficiency, the PTH levels go up further, and there is further demineralization of bone because of the mobilization of calcium and phosphorus from bone. And in the kidney, there is increased calcium reabsorption and reduced phosphorus reabsorption. But 125 dihydroxy-D concentrations are usually either low or low normal in severe vitamin D deficiency because of reduced availability of 25-hydroxy-D substrate. And as a consequence, there is not that compensatory increase in gut calcium and phosphorus reabsorption. And so in this state, we see a low or a low normal calcium with low phosphorus levels. Now, severe vitamin D deficiency can also mimic PTH resistance in the renal tubules and present with a pseudo-hypoparathyroidism type 2 kind of picture with high concentrations of PTH and an increase in PTH with low calcium but with high phosphorus. And these patients have very low levels of 25-hydroxy-D, and 125-dihydroxy-D would be low too. And typically, this PTH resistance seems to resolve with vitamin D replacement. Now, we know that vitamin D deficiency and rickets became first evident or at least became first well recognized in the Industrial Revolution, at the time of the Industrial Revolution in London and in many cities of England in the 19th century, when little sunlight could penetrate the atmosphere because of the very heavy smog. And thousands of children died from rickets and from bronchitis. Now, this resolved by the early 20th century because of reduced pollution, improved nutrition, and the use of cod liver oil. Now, rickets itself is derived from an Old English word for twist called or rick. And this term was, because of the bowed legs and the knock knees that the children had when they had rickets, they had a twisted appearance, and that's how the term rickets came about. So what causes rickets? Rickets is, so not all vitamin D deficiency is rickets, and not all rickets is because of vitamin D deficiency. So rickets is caused by a disorganization of the growth plate. Now, phosphorus is needed for the apoptosis of the hypertrophic chondrocytes in the growth plate. And in the absence of phosphorus, you don't get that apoptosis of the hypertrophic chondrocytes. And also, particularly if there's a reduced, when there's reduced concentrations of calcium or phosphorus, with a decrease in the calcium phosphorus product, there is undermineralization of the growth plate. And this leads to easily deformable bone at the growth plate, leading to some of the features that we see with rickets. And the causes of rickets include vitamin D deficiency and resistance and calcium and phosphorus deficiency. Osteomalacia is a different term, and this refers to undermineralized bone cortex and can manifest as bone or muscle pain. And while growing children can have both rickets and osteomalacia, once growth is complete, once the growth plates are fused, we only see osteomalacia. Now, calcium deficiency causes rickets, and this can be from vitamin D deficiency or rarely from a reduced intake of calcium. And these children may have normal 25-hydroxy-D concentrations. This has been reported from Africa, but it can be seen sometimes, even in more developed countries. Phosphorus deficiency, again, causes rickets. You really need phosphorus deficiency for rickets to be evident. And this can be a consequence of increased renal phosphate wasting, as occurs in hypophosphatemic rickets or Fanconi syndrome, and less commonly with nutritional phosphorus deficiency. So that's all I'll be talking about in terms of rickets, because the talk is really about vitamin D deficiency. So what are the signs and symptoms of vitamin D deficiency? So these children can present with limb pain and proximal myopathy, and this is probably why our patient was limiting his movement and not wanting to walk anymore. And if they have rickets, of course, they can be craniotabes, which is easily deformable bone of the skull. They can be frontal bossing, delayed tooth eruption, flaring of the wrists and knees, and our patient had all three of these symptoms, did not have craniotabes. These children can have rachitic rosary, which is a prominence of the costochondral junctions, the Harrison sulcus, which is a transverse indentation at the site of the insertion of the diaphragm to the ribs, and they can be genovarum or valgum. Now, if these patients have significant hypocalcemia, that can obviously manifest as seizures or tetany. So now let's move on to the causes of vitamin D deficiency and resistance. So an important cause is decreased cutaneous synthesis, intake, or transplacental passage. But obesity is associated with vitamin D deficiency, as is decreased GI absorption of vitamin D, decreased 25-hydroxylation in the liver, increased metabolism, and decreased 1-hydroxylation. So starting with reduced cutaneous synthesis, this can occur when there's reduced exposure to sunlight. And this red arc here shows the 37th parallel. And in the winter months, in latitudes that are north of 37 degrees, there's almost no cutaneous vitamin D synthesis. And this is because of the oblique path of sunlight during the winter months, when ultraviolet radiation is absorbed by the atmosphere before it reaches the surface of the Earth. Now, the figure here shows the effect of season on pre-vitamin D3 synthesis and concentrations. And this was a study in Boston in cloudless days of July in the summer and in the fall in October. And you can see that the concentrations are much higher in the summer months when the sun, when there is not that oblique path of the sun, of sunlight. And this figure shows the effect of skin cover on serum 25-hydroxyvitamin D concentrations after a whole body exposure to the minimal erythema dose of UVB based upon clothing worn simulating the various seasons. And we can see that in the fall, with fall-like clothing, the 25-hydroxy-D concentrations achieved are much lower than in the summer months. And then here is what happens when you use sunscreen. So even in the summer months with sunscreen, the vitamin D concentrations are going to be very, very low from cutaneous synthesis. Melanin is a natural sunblock, and dark colored skin, as you know, has more of melanin. And the tropics and the subtropics are really where we see people of darker color. And this is a protective mechanism, and this prevents excessive sun exposure in the tropics and subtropics and the subtropics, which has deleterious effects on the skin, as we know. But this protective mechanism becomes deleterious when people from the tropics and the subtropics migrate to areas of lower sun exposure, such as the temperate regions. And we know that people of Asian descent and dark-skinned people will require a much longer sun exposure than lighter-skinned individuals to make the same concentrations of 25-hydroxy-D. And this study showed that dark-skinned adolescents had 20 times higher risk of having 25-hydroxy-D concentrations in the insufficient range compared to white adolescents. Now, in terms of decreased intake, vegetarians are at a higher risk of vitamin D deficiency because they do not take fatty fish or certain meat products that have high concentrations of vitamin D, but particularly vegans are at very high risk of this. And in vegans, one consideration in terms of what kind of food they could eat to increase their vitamin D intake, if they do not want to take supplements, would be ultraviolet radiated mushrooms, which have high concentrations of vitamin D. Now, solely breastfed infants with no supplements also tend to have vitamin D deficiency because, as I mentioned before, breast milk has very low concentrations of vitamin D. And for an infant that is only breastfed, that infant would require to consume 8 to 10 liters of breast milk to get the required 400 IUs per day of vitamin D. So that's obviously not feasible. In contrast, fortified milk and formula have robust amounts of this vitamin, and therefore the recommendations are to supplement with a vitamin D supplement until the infant is consuming at least 1 liter per day of fortified milk or formula and is getting the 400 IUs from diet, as opposed to, and therefore would not require the supplements. And now moving on to maternal vitamin D deficiency in preterm infants. So the sole source of vitamin D in the fetus is transplacental passage from the mother. And so if the mother is deficient in vitamin D, the fetus and typically the infant will also have a vitamin D deficiency. And this study by Lee et al. Showed that 50% of dark-skinned mothers and 65% of their infants at birth have 25-hydroxy vitamin D concentrations of less than 30. Now, transport of vitamin D transplacentally is maximum in the last trimester. And so preterm infants do not have sufficient time to adequately build up their vitamin D stores. In fact, much of the fetal bone mineralization occurs in the third trimester. And so preterm infants are at risk for D deficiency. And if they require a TPN, obviously, if TPN is not appropriately supplemented with vitamin D, there can be deficiency from that cause. Obesity, we know, is associated with vitamin D deficiency because fat sequesters vitamin D, and it's still a little unclear what the implications are of the low 25-hydroxy D concentrations in people with obesity, but it's something that we still do treat at this time. Malabsorption conditions of malabsorption can be associated with D deficiency, and so celiac disease, cystic fibrosis, inflammatory bowel disorders, bariatric surgery, particularly Roux-en-Y gastric bypass, and medications such as cholestyramine and orlistat have been associated with D deficiency. If there is decreased 25-hydroxylation in the liver because of liver disease or because there are mutations in the gene that codes 25-hydroxylase, that leads to a decrease in 25-hydroxy D concentrations. And as alluded to before, the anti-epileptic drugs and the anti-HIV drugs, the antiretrovirals, can cause vitamin D deficiency by increasing 24-hydroxylase activity. And in the kidney, if there is kidney disease, and also if the patient is on drugs such as ketoconazole, there can be reduced 1-hydroxylation, leading to a reduction in the active form of vitamin D, calcitriol. Although 25-hydroxy D concentrations may be normal, and mutations in the 1-hydroxylase, in the gene that codes 1-hydroxylase would also lead to a reduced calcitriol production. Now, in nephrotic syndrome, 25-hydroxy D concentrations are low because of low concentrations of vitamin D binding protein, which tends to be excreted in urine. But the free concentrations of 25-hydroxy D are believed to be normal, and these patients will typically not manifest with symptoms of a D deficiency despite very low 25-hydroxy D concentrations. Now, in terms of the genetic forms of vitamin D resistance, so these are conditions where 25-hydroxy D concentrations are normal, but we see the effects of vitamin D deficiency. And this can occur when there is a deficiency of 1-hydroxylase, and that causes vitamin D dependent rickets type 1. And here the 25-hydroxy D concentrations are normal, but 125-dihydroxy D concentrations are very low. And this condition can be treated very effectively with physiological doses of calcitriol. And the second form of vitamin D resistance occurs when there is a mutation in the gene that codes the 125-dihydroxy D receptor, or the vitamin D receptor. And this causes vitamin D dependent rickets type 2, where again, we have normal 25-hydroxy D concentrations, but here we have very high 125-dihydroxy D concentrations because of increased 1-hydroxylase activity from the high concentrations of PTH. And this is a much harder condition to treat. It requires very high doses of calcitriol and calcium, and these patients may need a long-term treatment with calcium infusions. And these are the children who may have alopecia. So there are many red flags for vitamin D deficiency in our patient, obviously. So he had dark skin color, he was born preterm, he was breastfed, he had allergies to cow's milk and could not take fortified formula or milk. And he did not, so the mother indicated that he would not take any hypoallergenic formula because he just didn't like the taste, and he was not on any supplements. So how do we diagnose vitamin D deficiency and resistance? So vitamin D deficiency, as we all know, is diagnosed based upon 25-hydroxy D concentrations as measured by radioimmunoassays, HPLC or LCMS, and the gold standards really are HPLC and LCMS, but many immunoassays perform reasonably well. Now, we use 25-hydroxy D concentrations as an indicator of deficiency or sufficiency, but rather than 125-dihydroxy D, because the half-life of 25-hydroxy D is longer and it's not prone to the quick changes in concentrations that occur with 125D because of the changes in PTH and the effects of PTH on 1-hydroxylase. Now, the IOM has indicated that a 25-hydroxy-D concentration of more than 20 in all age groups should be sufficient for normal bone health. And consistent with this, the 2016 Global Consensus Recommendations for Rickets in Children and Adolescents indicated that vitamin D sufficiency is a 25-hydroxy-D concentration between 20 and 100. Insufficiency is between 12 and 20, and deficiency is less than 12, based upon data indicating that it's at these concentrations that we're most likely to see low bone density and rickets. The PES guidelines are, at least the state-of-the-art paper that we wrote many years ago, had very similar cutoffs for D sufficiency, insufficiency, and deficiency, except that the cutoff for deficiency was set a little higher at 15 nanograms per ml. And the Endocrine Society, of course, is the outlier in that it defines a level of less than 20 as deficiency as opposed to insufficiency, and a level between 20 and 30 as insufficiency, and more than 30 as sufficiency. Now, the basis of these guidelines and are really based, so the basis really was, how much of 25-hydroxy-D do we really need in terms of optimizing various endpoints? So some studies have used an endpoint of optimal gut calcium absorption, or PTH levels, but it's increasingly believed that really what should be guiding the 25-hydroxy-D cutoff for sufficiency or insufficiency is optimal bone mineralization, which in children would be prevention of rickets and optimizing bone density in accrual, and in adults would be optimizing bone density. So the Endocrine Society guidelines, when they use that cutoff of 30, so they used studies such as these, which showed that at serum 25-hydroxy-D concentrations of less than 32 or 30 nanograms per ml, there was a reduction in calcium absorption in the gut, or an increase in PTH concentrations. Now, in contrast to these endpoints, this kind of inflection in the curve has not been reported when 25-hydroxy-D concentrations have been plotted against bone density measures or fracture incidence or prevalence. And these are studies in children by Steve Abrams' group, showing that there really was no inflection at the 30 nanogram per ml point for 25-hydroxy-D concentrations in terms of PTH or for gut calcium absorption. So these studies did not show that inflection that was reported in the adult studies. In contrast, here is a study that shows the association between baseline serum 25-hydroxy-D concentrations with a change in bone density at the spine. And this was in peripubertal girls, and this was the change over 3 years. And there is that association of 25-hydroxy-D concentrations with bone accrual over time. And here's the 20 nanogram per ml cutoff. And we can see that all the participants who did not accrue bone over the next 3 years, so these were the patients with, or the participants with whose change in bone density was less than 0. They all had a 25-hydroxy-D concentration of less than 20, and most had a D concentration of less than 15. And there are other studies that suggest that low bone density is more common at a 25-hydroxy-D concentration of less than 15, and rickets is more common at a D concentration of less than 12 nanograms per ml, and hence the revised cutoffs. So 25-hydroxy-D concentrations would be low when there is primary vitamin D deficiency. Calcium concentrations in mild to moderate vitamin D deficiency, I've told you those concentrations are usually normal because of increased PTH levels leading to increased mobilization of calcium from bone, increasing the renal reabsorption of calcium, and increasing 1-hydroxylation, with increasing with higher calcitriol levels leading to increased gut absorption of calcium. But in severe and chronic deficiency of vitamin D, serum calcium concentrations are low. Phosphorus levels are typically low in patients with rickets and also and certainly in vitamin D deficiency. And if phosphorus levels are low with a high PTH, that indicates a primary calcium or a vitamin D problem. While if there is a low phosphorus with a normal PTH, that suggests a primary phosphorus problem. PTH concentrations are increased when there's a primary vitamin D or a calcium issue. And if there's a normal PTH in a patient with rickets, that suggests a phosphorus problem. Now, 125 dihydroxy-D concentrations are increased in moderate vitamin D deficiency and low or low normal in severe vitamin D deficiency because of reduced availability of 25-hydroxy-D substrate. And these concentrations will be markedly decreased in mutations of the 1-alpha hydroxylase gene and markedly increased in mutations in the vitamin D receptor gene. Alkaline phosphatase is always high in rickets. Creatinine levels could, if they're high, could clue one into renal conditions, and calcium excretion in urine is low in vitamin D deficiency. Phosphorus excretion in urine, if it's high with a normal calcium and 25-hydroxy-D, would suggest hypophosphatemic rickets. In severe vitamin D deficiency, when we look at radiographs, there is rarefaction of bone. Rickets is characterized by a loss of demarcation between the metaphyses and the growth plate, with the loss of the provisional zone of calcification. There's a whitening of the growth plate, and there's this metaphyseal widenings, splaying, cupping, and fraying. And rickets can be graded by the Thatcher score. Osteomalacia is characterized by rarefaction of bones and the appearance of pseudofractures. So how do we manage vitamin D deficiency? So I'll talk first about prevention and screening. The IOM recommendations are that all children that are less than a year old should take 400 IUs of, should receive at least 400 IUs of vitamin D, from diet or supplements, and that is considered adequate intake. For children who are a year old or older, the recommended dietary allowance for vitamin D is 600 IUs. And this meets the needs of 97 to 98% of the population. A small proportion of the population will need more than 600 IUs to keep their vitamin D concentrations in the normal range. Now, these numbers come from simulated dose-response relationships of vitamin D intake to 25-hydroxy-D concentrations. And the 600 IUs daily corresponds to a 25-hydroxy-D concentration of 20 nanograms per ml, even when sunlight exposure is negligible. And this holds again for 97 to 98% of the population, but not everybody. In breastfeeding infants, the maternal intake of 4,000 to 6,000 IUs of vitamin D daily is considered sufficient to ensure a sufficient 25-hydroxy-D concentrations in the infant because of that passage in breast milk. Now, this was an interesting study, and it has, it has been criticized somewhat in the literature, but it's still interesting. So this was from my colleague's group, and so in this experiment, they looked at 25-hydroxy-D concentrations in submariners after they had been in a submarine for 1.5 months or 3 months, and then 1 month after leaving the submarine. And when they received no supplemental vitamin D, their 25-hydroxy-D concentrations went down by almost 40%, and then kind of rebounded after they left the submarine. And it turned out that when they received 600 IUs of supplemental vitamin D, at the end of the 3 months, they were pretty much at baseline in terms of the 25-hydroxy-D concentrations. And so that suggests that the 600 IUs should indeed work. There's also a study in girls between 9 and 15 years old in the Growing Up Today study, and this involved more than 6,000 girls. And here they looked at the risk of stress fracture during 7 years of follow-up and showed that that was associated inversely with vitamin D intake, but not with calcium or with dairy intake. And the study also reported that those girls who participated in at least an hour per day of high impact activity, and these would be the girls who mostly had the stress fractures, those who were in the highest quintile of vitamin D intake and took more than 600 IUs of vitamin D per day, had a 52% lower risk of stress fracture than those who were in the lowest quintile and took about 100 units per day. So again, that 600 IUs per day dosage seems to actually work. But in general, we should be using common sense in determining how much of vitamin D to advise for our patients. And a dietary intake of 600 IUs per day is likely sufficient to maintain D levels and prevent vitamin D deficiency during the summer months in light-skinned children and in the absence of other risk factors. But there are certain conditions where you might want to recommend higher vitamin D intake on a daily basis, and these would be patients with malabsorption, with liver disease, people who are on medications that cause increased metabolism of vitamin D, patients with obesity, and potentially also dark-skinned people who live in the northern latitudes, particularly during the winter months. So who should be screened for vitamin D deficiency? Really anybody that is at risk for deficiency and those who have symptoms or signs of D deficiency or rickets. And in terms of treatment, so we know that we now have pills and capsules of varying strengths, and we have a generic liquid that has 8,000 IUs of vitamin D per ml. And the dosage for treating vitamin D deficiency ranges between 1,000 to 10,000 IUs per day, given for 6 to 8 weeks. For children who are less than 12 months old, the recommendation is to give 2,000 IUs per day for 6 to 12 weeks, followed by 400 IUs per day. For those that are 12 months or older, the recommendation is at least 2,000 IUs daily for 6 to 12 weeks, followed by a maintenance dose of 600 to 1,000 IUs daily. Or you could give the 50,000 IUs high dose preparation once a week for 6 to 8 weeks, followed by 600 to 1,000 IUs daily. Children who have obesity or have malabsorption and those that are on medications that impact vitamin D metabolism will need higher doses, upwards of 6,000 IUs daily, followed by higher maintenance dosing. And the children who have established rickets from vitamin D deficiency also seem to need higher treatment doses. So if they're between 1 and 12 years old, 3,000 to 6,000 IUs daily for 12 weeks, followed by maintenance should work. And if they're 12 or older, then they will require 6,000 IUs daily for 12 weeks, followed by maintenance. But many of our patients have required higher doses, and I'm sure yours have too. Now, in patients who have a high PTH or have evidence of rickets, it's important to also replace calcium. And the dosage is 30 to 75 milligrams per kilogram of elemental calcium given in divided doses for a period of 2 to 4 weeks. Now, once you're back down to maintenance vitamin D dosing, you don't need to give calcium anymore unless dairy intake is limited. So why do we need to do this? Mostly because we want to prevent the hungry bone syndrome. And so what is the hungry bone syndrome? This is the hypocalcemia that can occur because of vitamin D replacement and a normalization of PTH concentrations, leading to reduced bone resorption and increased bone mineralization. So the mobilization of calcium from bone kind of ends when PTH normalizes. And that can lead to this condition. Patients who have symptomatic hypocalcemia at the time of diagnosis of vitamin D deficiency will require IV boluses of calcium gluconate, followed by a slow infusion of calcium where they have persistent hypocalcemia. And in some of these patients, calcitriol given at a dose of 20 to 100 nanograms per kilogram for a few days can also be helpful in normalizing and getting the calcium levels to normalize faster. In terms of monitoring, in infants and those who receive more than 2,000 IUs daily of vitamin D, it is important to reassess calcium in 1 to 2 months to rule out hypercalcemia occurring from inactivating mutations in 24-hydroxylase. And this would lead to increased 125-dihydroxy-D concentrations, leading to hypercalcemia. And this is something that we see in infants sometimes, and this has been referred to as idiopathic infantile hypercalcemia. In general, I reassess vitamin D status at about 8 weeks, and then again in 2 to 3 months, and then once a year, and that typically suffices. Now, as regards whether we should be giving vitamin D2 or D3, so D3 is cholecalciferol that comes from animal sources and is present in many supplements. D2 is ergocalciferol, and that is derived from plant sources, is also present in many supplements. And pharmacological vitamin D is typically a D2 and not D3. Now, both D2 and D3 will raise 25-hydroxy-D concentrations and will prevent and treat rickets. But it does appear that vitamin D3 increases 25-hydroxy-D concentrations to a greater extent than vitamin D2, and it can maintain those concentrations at a higher level for a longer time, particularly at higher doses. Now, if a child has poor response to therapy with vitamin D, think about non-adherence, think about malabsorption, liver disease. And also in rare situations, if vitamin D binding protein concentrations are low, your 25-hydroxy-D concentrations will not increase even with treatment. So our patient received 7,000 to 8,000 IUs of vitamin D daily with supplemental calcium. And with this, and he actually required these high doses to get his 25 hydroxy D concentrations above 20. And as you can see, within we didn't repeat his X-rays until 6 months after treatment. You could repeat it as early as 1 month, but you can see how nicely his rickets has healed. So I've reviewed with you the physiology of vitamin D, the causes of vitamin D deficiency and resistance, the causes of rickets, the diagnosis of vitamin D deficiency and also resistance, and the management. And I'll end here, and I'm happy to take any questions. So there's one question: if we are melanin rich, that time is longer. Yes. So if people have, so for darker skinned people, the duration of sun exposure to get sufficient 25 hydroxy D concentrations is much longer, and it can be as much as it can be very long. So so is anyone outside between 10 and 3 p.m.? That's a great question. I don't know the answer to that. I guess if you are a runner, you might be. Do you normally check urine calcium creatinine ratio to discontinue calcium supplementation in rickets? I actually don't do that. I give calcium until the PTH levels normalize. I check the calcium levels to be sure that patient is not getting hypercalcemic. I don't routinely check the calcium, the urine calcium creatinine ratio, although you could. It would be a reasonable strategy to assess when to stop the calcium supplement.
We have a question in here.
What about a high vitamin D level? So that's also interesting. So what about vitamin D concentrations of more than 100 or more than 150? So those are some of the cutoffs for hypervitaminosis D. If the vitamin D concentration is more than 150, that is vitamin D intoxication. That would be associated with hypercalcemia potentially, and so you do want to be sure that you don't exceed those levels. When the levels are more than 100 nanograms per ml and between 100 and 150, that typically has not been associated with hypercalcemia. And we may be out of time now. Are we out of time?
Do you do any dust therapy of vitamin D?
I'm sorry, I could not hear you.
Do you do any STAS therapy with vitamin D?
STAS
high doses? Yeah.
STAS therapy, no, I do not do that. Particularly with the preparations that we have here, I worry a little bit about STAS therapy. You could probably do it with the vitamin D capsules. It's easier to do it with, one would be tempted to do it with the liquid, and you probably know that the liquid has propylene glycol, which if given in robust doses can have toxic effects. So there is potentially a way to give vitamin D capsules in higher doses to do STAS therapy. I have personally not done that. The weekly dose of the 50,000 IUs per week seems to work for my patients. I've not had to do STAS therapy, but it's a very effective strategy for patients who are, vitamin D deficient in the underdeveloped countries where follow-up may not be great. And so giving a very high dose of vitamin D in the range of 600,000 IUs as a single dose can be very, very effective therapy and does not have to be repeated for at least 6 months at a time. And then there's another question about how aggressive are you in correcting vitamin D concentrations in very obese children with normal PTH, bone minerals, and normal alkaline phosphatase. So this is a very problematic situation because we really don't know what those low 25 hydroxy D concentrations mean in obesity. And I'm still correcting it. I'm not sure that I'm doing the right thing. Mostly I'm correcting it because I don't know what else to do. But I hear you in that, if you have a normal PTH and a normal alkaline phosphatase, is it meaningful to correct the low vitamin D concentrations? Would you recommend vitamin D screening for well child visits? So the answer to that is, if a patient is at risk for vitamin D deficiency, then I would screen. If not, I would not.
Dr. Misra, thank you so much for this excellent presentation. And by the way, Dr. Misra is the immediate past president of the Pediatric Endocrine Society.